Ralph, how long have we known each other? 25 years?
At least 25, Ken.
Must be at least
Back
that long.
at the time when you were at a place called Mayo in
Oh, I remember that. Some little place in Minnesota,
Minnesota.
wasn't it?
That's
Yes.
correct.
That time you were out in a state that had a lot of sunshine.
That's right.
I think we had more snow than you did, though.
You had a lot more snow, and I met you through some of the senior doctors there, many of whom had a relationship with Hawaii.
Who was that?
I'm trying to think what his name, the big heavyset surgeon. I'm blocking on his name now, but I can see his picture. Anyway, they had a travel club.
Yes.
And it used to come to Hawaii.
Yes.
And then I used to...
That's exactly right. I remember that.
Used to have to set up sessions for them and everything.
Let's see, you grew up in Illinois, right?
No, I grew up in West Virginia. I went to Illinois to undergraduate and medical school.
Undergraduate and graduate. West Virginia isn't known for being one of the more progressive states or one of the richest states either. What was your background there?
Well, my mother was a school teacher. My father worked for the power company. He was actually an engineer, but his job was mainly administrative. But I came from a family of doctors and lawyers, many of whom had grown up there. Actually, I came from a family that was one of the earliest settlers in the area.
Really?
Prior to becoming West Virginia, it was part of Virginia.
Virginia.
And I have a relative that in the 1800s, early 1800s, because I have documents, was actually the county commissioner of the area. So our family's been there for many, many years.
And then you went to Illinois for school. Did you want to be a doctor when you went to college, did you think?
Sometime around the 7th or 8th grade, I decided I wanted to be a physician. What kind of physician, of course, I didn't know. And I decided I wanted to go to the University of Illinois. I had a couple of my relatives, an aunt and an uncle, who went to Illinois, and I had been out to visit it. And believe it or not, at that time, it was easier to get to Champaign, Illinois, than it was to get up to Morgantown, West Virginia.
No,
because
really?
it's the opposite part of the state. So that's why I went there. And then when I finished, actually I didn't finish. I got into medical school after the 3rd year. And I was accepted at 5 medical schools, but I was comfortable in Illinois. I had met my wife-to-be at that time, who was from Illinois, so I went to the University of Illinois in Chicago.
I think that was a good choice, right? When did you decide you wanted to do women's health care?
Actually, I entered medical school, and through my first 2 years thought I was going to be an internist. But I was interested in endocrinology because during the time I was in undergraduate school, I'd spent a lot of time in chemistry. As a matter of fact, my major was ultimately in organic chemistry. And I got involved in a number of issues like that. And when I got to medical school, I took a job working in the biochemistry department. And I was working with an internist that was doing chemotherapeutic agencies. As a matter of fact, we were working on 5-fluorouracil at the time. I actually did produce it at one time, but it was too late. It had already been patented by Heidelberg in Wisconsin. But at that time, I thought I was going to be an internist, get very active. And then I took my first rotation on OBGYN.
And who was it on that rotation that made you see the light?
Well, I don't know there was anybody specific that made me see the light, except that I enjoyed the surgery. I enjoyed the ambulatory care aspect of it. And I think one of the things that probably really influenced me the most is that at Illinois, you were allowed to take your rotations at different hospitals, or basically required to. I took my rotation in Presbyterian Hospital. Well, Presbyterian Hospital, which is, of course, in the medical center at Illinois, they had the long-term history of being very student receptive. Oh. And there was a gentleman named, I still remember him, Vernon Truckley, who was in charge of the training program for residents. But he was very student-oriented. And I'd hardly been on the service the very first week I delivered my first baby. You know, you deliver a baby as a student, and it really catches.
And I think for a lot of us, that was, if you enjoy it, you just
It was.
There's nothing else, right?
There was nothing else. I enjoyed it immensely. And I never regretted. I had the opportunity because when I started my residency, I wanted to leave Chicago. I took a residency in Akron, Ohio, at the Akron Hospital, Akron General it was called at that time. And they had a very good training program. Of the 19 interns that went there, 17 of them were from my own school, Illinois, because there was a very close relationship over the years. And I was in the program, internship, finished my internship, and started in the OB program and was drafted. I was drafted in October of my first year. I didn't have to report until January the first year, so I had basically 6 months. And then I went into the military. When I finished my military commitment of 3.5 years, I had the option to go almost any place I wanted to go in the United States for a residency or to take any type of residency. But I was very comfortable. Fortunately, during the time that I was in the Navy, I was stationed in Hawaii, I was able to go to Tripler Hospital. I was able to work within the OBGYN department there. I met some very wonderful OBGYNs that were very influential in convincing me that that was the specialty I wanted. And I have never had a regret.
And you were in Hawaii for how many years?
I was in Hawaii for over 30 years.
30 years. How did you decide to stay in academic medicine instead of going into private practice?
When I finished my training, actually the year before I finished my training, I had a lot of offers. A lot of people were interested in it. One of the offers, which I very seriously considered, was made by Dr. Warren Pierce, who was my predecessor at the college. Dr. Pierce wanted me to come and join him at the University of Nebraska. That made me begin to think about an academic career. Prior to that time, I hadn't thought that much about it, although I had already 4 research papers, including the #1 issue in the Green Journal on Krukenberg tumors while I was a resident.
Really?
So I was very interested in research. At that time, they were developing a medical school at the university. And one of the people that was doing it was a gentleman named Terry Rogers, a PhD physiologist, who subsequently became the dean of the medical school. And he recruited an OBGYN named Robert Noyes. Bob Noyes, well known in our specialty because he's the one that dated the early endometrium.
Oh, he was
Worked with Rock and the group out of that.
Sure.
Researcher, he came over from Stanford. And during the time I was in the residency, Bob kept encouraging me to consider an academic career. So as I got near the end, Warren had convinced me that I could do it in academics. The medical school asked me if I would be willing to join their faculty 20% to be just a teacher. Well, of course, I needed another 80%. I certainly needed the work. And one of the large groups in Hawaii, the Straub Clinic, said they'd be willing to take me. As a matter of fact, they recruited me very strongly. And so I joined them with the understanding I could spend 20% of my time with the university. I enjoyed that time with the university immensely. And so 2 years later, I made a decision that I was going to go full-time with the university as soon as they were able to put me on full-time. My commitment to the university continued. I joined the university full-time in 1972. At that time, though, there was no OBGYN department, of course, because we were still a 2-year medical school. So what I became was the Associate Dean for Student Affairs. And I worked with the students. But also at the same time, I was in the process of establishing what would be the ultimate OBGYN department. So working with the hospital where I'd had my training program, and Dr. Jack Krieger was still the program director at that time, we began to set up student clerkships. We did those student clerkships so that we could get the feel of how our hospital and how our program could work, since we didn't have a university hospital. We had agreements, affiliation agreements with the major hospitals in the community. And then under the old Hill-Burton funds, they got money to the university so they could build floors on the existing hospitals. So,
so they added on to the already existing hospital?
They added on to the existing hospitals in such a way that I was able to develop basically a department floor, develop a program. So in 1974, when they voted to go to a full four-year school, I moved over from the Associate Dean for Student Affairs to the full-time chairman and professor. By that time, I had enough research, had gone through enough tenure and promotion that I had been raised to the level of associate professor and was up for professor and tenure during that same period.
That's pretty fast, Ralph.
It was exceedingly fast, but I was at a new school, and a new school that was willing to work. And by that time, I had some 40 or 50 research papers.
Now, you were chair there until you joined the college. What year was that?
I joined the college in 1993. I became from 1974
to 93.
To 93.
I don't want to jump there yet because I know there were a lot of programs you developed while you were chair, Pacific Rim programs and so forth. Of all those programs, what were you most proud of? Which one do you remember most fondly and think you did the most good with?
Well, I think the thing that we did the most good with was something called the Dean's Guest Program. And that was a program where we went into the Micronesian islands and we pulled out good medical students, potential medical students. We brought them in, we gave them a 6-year training program, basically 2 years of undergraduate training, 4 years of medical school, and then they were eligible, of course, to graduate as a full MD. And many of those went on to go back into their own areas to practice. Many of them did not. Some of them are still in this country. Some of them are OBGYNs, and I occasionally see them here at our annual clinical meeting as they come in. I think that was probably one of the nicest things. But it's hard to say how much fun you get of starting a medical school from scratch, starting clerkships from scratch, doing all the things you needed. I used to fly around the country to places. One of the gentlemen that was most helpful to me was Ron Ches.
Sure.
Because he was at Pittsburgh at that time, and they were developing very innovative education programs. And since we had no history, anything we wanted to do, we could do. So we started a history. We took his history, we just made it our history and moved on from there. So that was the good thing.
Oh, that's great.
It was also fascinating. In the early years of our residency, as I was first there, we really were not in the match because nobody wanted to come to Hawaii to a new program that had no history. So a lot of the people that...
I don't know. Hawaii's pretty attractive, Ralph. You might have filled right away.
That's true. But none of the other programs were in it, and it was still looking that way. What we got is a lot of applicants from people that I don't think you would look at a real traditional school, because they were people who were interested in being, I guess, at the forefront of something new and different. We had individuals who came out of other programs that wanted to get involved in Micronesia, Trust Territories, the Asia Basin, things like that. And that was also the way the medical school was. And it was interesting over the years as the medical school became a more traditional, as it is now, a very traditional medical school, to see the change in the students. And I really liked those early students, and I liked those early residents that I was able to get. I had one resident, for example, just to give you an example of it, that had spent 3 years in Uganda as a missionary.
Before going to residency?
Before going to residency. He was just a family physician. Had gone over there as a missionary and worked and realized there was this real need. And he wanted to come back to a program that was not a set, stable program. He wanted one where he felt he could really learn. And at that time, we had rotations through Micronesia. We'd send faculty down to, for example, Truk, send them over to Saipan, places like that. That's where our residents would go, and we'd send a faculty member with them. But they'd take care of really third world medicine. And it was really very fascinating. Enjoyed that.
What an opportunity. There's no one else has had that opportunity, have they?
I know of no one else that's been able to or had the opportunity to move into that. And that was wonderful. Now, of course, we're medical school. When I left, one of the reasons I left was because, well, the main reason I left was because of the job at the college, which is one of the few jobs. Over the years, I'd had other inquiries about would you be willing to move to this university or that university. And I had given it some thought. And I felt at that time, when the job to college came up, I'd probably been able to accomplish as much as I was going to be able to accomplish.
That was going to be sort of my next question. It's a big change from Hawaii to Washington, D.C., from practice to running a big organization, and it was just the right time, right?
It just happened to be at the right time. I would have preferred if it had been maybe a few years later, but opportunities, you have to either take them or you lose them. And I felt this was an opportunity that I wanted to do. I liked to do it. It was kind of interesting. It was following Warren again, who I thought the most of, and probably even more interesting, the head of the practice division at that time was Harold Kamenetsky. Now, Harold was one of my medical student instructors, who I thought the world of. He also, incidentally, gave me the pathology part of my boards when I took my boards. I often told Harold that he had to be careful with his students. Sometimes they become his boss.
Well, you know, you had a hard act to follow. We all know and love Warren, and he was a giant, is a giant. We saw him today here, and I actually saw Harold today, too. But how did you put your own individual stamp on ACOG? Because everyone knows now that you have, but what was it you wanted to accomplish when you went in there? Times change and things need to change, so what was your vision?
Well, my vision when I came to ACOG was that it was an organization that was well run, had great potential, and there were a lot of things you could do. But I was also seeing toward the future, because I knew medicine was going to change. Mm-hmm. You could already see the changes starting to take place in the 80s. And you knew from the presidential elections that actually started in the 90s before we got to 92, right, that there were going to be changes. And I felt they were changes that I would like to at least be able to say I had some influence on. And I think we did. When I came to the college, the first thing that I did was I took out every single minute that the college had ever had, starting in 1951, and read them all so that I could get a feel for the history. I learned during all of that my professor in medical school, Dr. William Minkert, had been actually a very instrumental part of establishing the college around the time that I was in medical school.
Really? I didn't know he was that much a part of the beginning of it.
He was a secretary.
I didn't know that.
And he was very active in the college. Of course, he became president of the college. Right. But this would all have been in the late 50s when I was actually in medical school. I graduated from medical school in 1960. Of course, as a student, you didn't know any of that.
Right.
Didn't understand all of that. Also, it was interesting as I went back and looked at it to realize how the college had started out as a very elitist organization and very rapidly evolved into an organization for the practicing physician. And I really respected what our forefathers did on that, because I think they recognized the need, and it wasn't what they'd started out doing. I was fortunate that one of my mentors in residency, and one of the people who I still think the world of that had a tremendous impact on my ability to practice and I learned from, was a gentleman named Colin McCorriston. Colin, at the time that the college was being considered in the late 1940s, was a resident in Boston. And he came to Honolulu. And at that time, during the AMA meetings, they always had large groups of city and state so-called societies come together. And in 1946 in Atlantic City, I learned this subsequent, he was present as a fly on the wall because of his Boston connection when the first decision was made to form the American College. So I found reference to him in some of our documents. So I went back and I actually talked to him and found out a lot more about our history and how it came to be and how that first meeting in Atlantic City, everybody decided. He knew Clay Beecham, our first president. Sure. He knew Woody Beecham. He knew all of these people because he had been training with Rock and Hurtig and the group in Boston at that time. So that kind of gave me a little insight into the early days of the college. Then in '56, when they became the college, and you begin to read through the minutes and see how the college had always been very progressive, it very obviously came to me that the college has to be a viable, but it has to be a very pliable as well as viable organization that moves to meet changes. And that's
I
the way
guess
it's been.
that's the thing I'd be interested in now, is that looking ahead 10 years from now, 15 years from now, what do you think the role of the college will be in women's health care and in medicine in general?
I think college is probably going to take a more central role, not so much in the surgical aspects of care, but in the medical aspects of care. I see the future of medicine in general as being less technically oriented and more patient oriented in terms of what we can do. Let me give you an example. When you and I trained, vaginal hysterectomy was something everybody did, and there were lots of them. Nowadays, you don't see many, and part of the reason you don't see many is because we've gone to first to Birch procedures and then to Pereira procedures, and those procedures that had a lot to do with the pelvic floor and reconstruction, and those did not include a hysterectomy. So nowadays, we're now seeing meshes, we're seeing other changes that are taking place. Abnormal uterine bleeding used to always be 1 or 2 DNCs and then a hysterectomy.
That's right.
Nowadays, you do 1 or 2 DNCs if you want to. Most people do 1, and on the second one, they do a hysteroscopy and some sort of endometrial ablation. And I think these changes are going to mean we'll be doing less surgery, which is probably not bad, because with the new evolving subspecialty of pelvic reconstructive surgery and with our gynecologic oncologists who are trained in complicated surgery, they're probably going to be the ones that will need to do the surgery. The average practitioner will become more of a, I'll have to say, a minimalist. I see that as our future. The laparoscope, of course, has changed tremendously.
Oh, tremendously.
I mean, used to do exploratory laparotomies all the time, and that's where you really got your skill at opening, closing an abdomen. Nowadays, you stick in a tube, and it's still complicated, but it's much less complicated than opening up a 500-pound woman or something like that, which you needed to do.
And it's certainly better for women, just in general.
Yes, it is. I still remember when I was a resident, we had what was called a maternal infant care program. Remember those funded by Health and Human Services?
Yes.
Well, we had a clinic up in on the Kaha side of Oahu where we had an MNIC clinic. And one of the faculty members, that was for our residency program, wasn't for the university, used to go there and see patients and bring them in to deliver. And they'd be in the hospital for 1 or 2 days, and they wanted to go home, and we'd discharge them. We got a letter from what is now HHS criticizing us because we were not keeping these patients 5 days, and we were not giving them optimal care. When we got into the position of the draft-through deliveries, I often wish I had kept that letter.
That would have been, actually, that would be a good thing to put in the museum.
That would have been a
That
wonderful
would be
thing to
great.
put in a museum. But that's just typical of the changes that we're seeing to take place. I don't think the role of the OBGYN in terms of obstetrics is going to change. I think we're still going to need obstetricians to manage pregnancy, manage labor and delivery. But I see the evolution much more of what we now see as the hospitalists. I think we're probably going to move closer to the European system, where a lot of ambulatory care is done by people who do not do the in-hospital care. For the college, I think this means we have to be very adaptable to the changing roles, because all of these people are going to need to have us be developing educational materials, resources, the things they're going to need to have their best practice.
We're running out of time, but one last question. I know that you have thought that the American College of Obstetricians and Gynecologists should be more than the North American College of Obstetricians and Gynecologists, and your expansion of the college into other areas has been remarkable. What do you see the future for that?
Well, I think it's no secret that I'd like to see all of the U.S., the U.S., all of the North and South America have an intimate relationship with the American College. This is not so much because I want to see us to be expansionists, As a matter of fact, just the opposite. I think it's because I want to see women in all of the Americas have the benefit of the best of health care. A number of years ago, when I really began to think about this, and I began to look at maternal mortality figures, it really bothered me that here in our own backyard, in countries like Bolivia, countries like in Central America, Guatemala, Nicaragua, El Salvador, had maternal mortality rates which were the same as sub-Saharan Africa. And that just didn't seem right to me. I mean, we needed to make our materials available. We need to work with them. One of the central components of our, quote, expansion has absolutely nothing to do with the college moving into those areas, but with working with the physicians in those areas so they themselves build their own skills, build their own infrastructure so that they are changing it themselves. Not that we're going down. I've always thought it was wonderful people went on 2- and 3-week tours and did lots of surgery and things, but then they leave, and that just leaves the rest of the people. And what we need to do is we need to work with the people, work with those OBGYNs in the area so that they become equivalent to the same level of health care which is being given in the United States.
So that's a remarkable vision. And Ralph, thank you so much. It's been a great pleasure.